Hello, everyone. Welcome back to Psych 260 Abnormal Psychology. And we're going to talk this week about Chapter 5, which is anxiety and obsessive compulsive and related disorders. So, even though obsessive compulsive and related disorders is in a separate category as anxiety now, there's still an underlying anxiety theme amongst all of these disorders. So, they've been grouped together in Chapter 5. So, what distinguishes fear from anxiety? Fear is a state of alarm in response to something that's known. There's a known threat to your well being, your fight or flight response gets kicked in, gets activated. Uh, basically, your stress hormones get released, and epinephrine and norepinephrine causes the adrenal response, right? We'll be talking about this when we get to the acute stress disorder and post traumatic stress disorder. But basically, your body's preparing you to act, fight or flight. And with fear, there's a target of that response. So if you got bit by a dog when you were young, if you see a dog, now the fear response kicks in because it's a conditioned phobia. It's known. Anxiety is this kind of vague sense of danger. And people feel this quite often. It could be in pretty much all the time in the case of generalized anxiety disorder, where people have this moderate level of resting anxiety. Or it could be in social situations, which is a social anxiety disorder, where people feel this sort of moderate level or severe level, in some cases, of anxiety in a social situation. They're both physiologically the same. The only difference is fear is targeted, anxiety is just kind of um, worried about possible danger. You get the same physiological reaction: increase in respiration, breathing, perspiration, sweating, muscle tension, heart rate, blood pressure goes up, and then you either fight or flight. Most of the time you're going to engage in flight, especially if you determine the situation to be overtly dangerous. Anxiety disorders are the most common mental disorders in the US. In any given year, 18% of the adult population experiences one of the six DSM-5 anxiety disorders, and close to 29% of the population develops one of the disorders during their life. So if you see incidence rates, it's 18%, and then prevalence rates are 29%, lifetime prevalence. Only in one-fifth of these individuals seek treatment. So basically what that's saying is that most people are dealing with their anxiety in some way, maybe not effectively, because they're not seeking treatment. So it could be interfering in your life for quite a long time, and you choose to ignore it, but then it gets to a point where you can't ignore it. It's ruining your life, and eventually you might decide to seek treatment, or you can treat yourself. You can, use alcohol, use drugs. Those are maladaptive coping responses, but people engage in these coping responses all the time. Most individuals with one anxiety disorder also suffer from a second disorder. That's comorbidity. For example, there's comorbidity with anxiety and depression. There's comorbidity with two different anxiety disorders. For example, panic disorder and agoraphobia are comorbid. Generalized anxiety can be comorbid with social anxiety, depending on where the extreme anxiety is occurring, if it's in a social situation or not. There's lots of comorbidity among anxiety disorders. You could have a simple phobia, and you could have generalized anxiety disorder. Those are just some of the possibilities. So it's a serious problem in our society. A great many millions of people are suffering from anxiety disorders each year, and the vast majority of these people are doing nothing about it. I mean, nothing productive in terms of seeking treatment. Here are some of the major categories of the anxiety disorders. We have GAD, generalized anxiety disorder. We have phobias, panic disorder, obsessive compulsive disorder, which is related. It's used to be part of the anxiety disorder complex. Now it's sort of related but kind of stands alone in the DSM-5. Acute stress disorder, which once again has its own category, and the same with post-traumatic stress disorder. So PTSD and acute stress disorder kind of go together. Obsessive compulsive disorder is separate from those two. It's also separate from the major anxiety disorders. But they're all related because there's all an element of anxiety and or fear in each person's case that are suffering from these disorders. So even though they're all related, they can be classified somewhat separately based on the DSM-5 reorganization. So GAD, generalized anxiety disorder, is this excessive anxiety under most circumstances and worry. So it's this low level or moderate level anxiety that's always there. And it starts the moment you wake up, and it continues until you fall asleep, or most likely until you don't fall asleep. You could be sitting in bed, laying down in bed, trying to sleep, and you're having severe insomnia, especially falling asleep. That's where GAD really shows up. And sleep problems could be the only symptom of GAD that you can notice. And so you go to your primary care doctor and they treat you for insomnia, but insomnia is not a disorder. Insomnia is just a symptom. So now what is the underlying disorder that's causing the insomnia? Could be depression, could be anxiety, could be GAD, could be a combination of these disorders. That's why, and it could be a physiological condition, a physical condition like hyperthyroidism, too much thyroid hormone. Very rarely it could be pheochromocytoma, which is an adrenal gland tumor, but that's like astronomically rare. But once you rule out all this stuff can be ruled out with blood and urine tests. And if your blood and urine come back normal, and you're still having insomnia and you still feel anxious, it's probably a psychological condition. And now you have to determine, is it GAD? Is it social anxiety? Where is it happening? How often is it happening? How severe is it? Those are all questions that your clinician will be probing and drilling down into. And it must last at least 6 months. So this is not like, 2 weeks of occasional problem sleeping. It's pretty normal to have occasional problems sleep insomnia. But when the insomnia becomes more chronic, then it becomes possible that it's due to an anxiety disorder or PTSD or acute stress disorder, depending on the length and whether there's a trauma or not. It also depends on whether you have nightmares. So nightmares are more common with acute stress disorder and post-traumatic stress disorder, especially the thematic nightmare, like reliving the trauma in your dreams, having nightmares of the traumatic situation over and over again. That points it more towards post-traumatic stress disorder. But this general feeling of anxiety and just not being able to sleep at all, fall asleep, is a characteristic of GAD if it lasts 6 months. Disorder is common in Western society because we live in a very individualistic, very stressed out world. I mean, our society is just amazingly stressful. There's lots of competition. There's lots of inequality. There's forces like racism, sexism, people that are born into impoverished living that have difficulty escaping. These are all major stressors that can add to the development of GAD. So it's very common in Western society. That's not to say that it's not common in the rest of the world. The rest of the world does have issues or problems with anxiety disorders. It depends on where you go and at what rate do they diagnose them. So for instance, if you go to certain Asian countries, they're less likely to diagnose you with, say, depression or with, say, GAD. They're more likely to diagnose you with a physical illness instead. And it could be cultural because psychological problems are not only taboo for the person who's suffering, but they're also taboo for the family. And in more collectivist societies, the Eastern Asian societies, the group or the family is put before the individual. And any kind of psychological abnormality would be shared amongst all family members or the members of the entire group. So there may be more of a cultural tendency to differentiate these people in Eastern cultures with physical illness rather than psychological illness. That's not good. That leads to poor treatment and poor outcomes, but it's a cultural phenomenon. Whereas in Western countries like the US, we're more individualistic. We put the individual ahead of the group, and as a result, we're more likely to get treatment, and we're more likely to sort of keep that treatment to ourselves. And women are obviously more likely to get treatment than men. There's very low levels of people with GAD getting treatment. So many people are out in the world with GAD, suffering and not doing anything about it, or trying to self-medicate. According to the social cultural perspective, GAD is likely to develop in people faced with social conditions that are dangerous, like natural disasters in war zones. That makes a lot of sense. You're dealing with chronic stress, pandemics, right? So we'd expect that to spike GAD even further. If you're dealing, if you're in Syria, which is a war zone, you're dealing with bombs, you're dealing with explosions, deaths all around you. It's very normal for you to have a high level of constant arousal. You become hypervigilant. You start scanning your environment for danger. And if you're in a war-torn area, you're going to find danger pretty much everywhere, which is just going to exacerbate your anxiety. You're going to develop GAD at a higher rate than if you're living in a place that's not considered dangerous. And one of the dangers that is not natural disaster related is poverty. If you're living in extreme poverty, that's one of the most powerful stressors there is. You don't know where, am I going to pay the bill for my utilities, for my mortgage, for my rent, for school, for anything, for food? Where am I getting the money? Am I ever going to find a better job? Am I going to find my job if I've been fired? Am I ever going to get out of this situation? And that's a chronic stressor that can easily lead to GAD. So poverty is a risk factor, and also African Americans have a higher risk factor, and I think that mainly is concerned with racism. And poverty plays a part in it as well. But you have a lot of racism in this country. I mean, if we weren't aware of that before, we're certainly aware of that now. Over recent times and the events that have unfolded, we've seen it more clear than maybe we would have liked to see it. Maybe we were in denial. We were thinking that, oh yeah, this is, Rodney King. That's not going to happen again. That was an isolated incident. No, it wasn't. It was never an isolated incident. You just didn't hear about it as much. But these were common occurrences, maybe not as seeking publicity or getting as much publicity as say Rodney King, which was a brutal situation. But now you're starting to get more and more through social media, through the police body cams in case of police justice issues or police racism issues. But even outside of police, I mean, I don't want to narrow this down to like police are all bad, because they're not. There are plenty of good police. There are bad police. There are racist police. There are non-racist police. Just like in anywhere else in the society, there are people that are racist and there are people that are not racist. But the fact that that's being brought to our attention more is sort of should be a wake-up call to the fact that this country is a long way away from diminishing, prejudice and racism, and then also sexism. And you're seeing that more with the Me Too movement, things that some men were once getting away with that were inappropriate, that were sexual harassment or sexual assault, are now being viewed in a different light, and people are willing to come forward and say this was not right. This is what happened to me. This is not right, and this should never happen again. So as a society, we're a long way away from diminishing all the stress that accompanies racism, sexism, poverty. We're not even close. Can we make progress on these issues? Of course. Can we make progress on poverty? Of course. We have to be willing to help these people, and a lot of them are mentally ill, especially homeless people. Many homeless people are mentally ill. So you can't just put them in a shelter and say, okay, I put them in a shelter, I've taken care of them, now they can go out and get on their feet again. No, they can't. They're mentally ill. You're not treating them. You're putting them in a shelter. You might give them a couple meals, allow them to take a shower, clean themselves up, but then you're throwing them back on the street. And you're not treating the underlying cause. And a lot of times the underlying cause is schizophrenia, psychosis. Yet that's not being treated. Drug addiction, another thing that's not being treated in the homeless population. So there's a lot of problems here that as a society we have to address. Otherwise, not just GAD, you're talking about very high rates of all kinds of psychological disorders, which ruin people's lives. And women, as I mentioned before, are diagnosed more than men at a 2-to-1 rate. And that's pretty normal because women seek treatment for their problems while men tend to deny and self-medicate. That's also cultural. From a psychodynamic or psychoanalytic perspective, Freud believed that children punished for expressing impulses develop anxiety later in life. So if you didn't express, if your id was not gratified during the oral stage or the anal stage of development, which is infancy and early toddlerhood, these children are more likely to develop anxiety because their parents said, don't put that in your mouth. Now, the child is trying to learn about the world by putting objects in their mouth, and the parents yelling, don't do that. The parent is not able to express their id impulse. They're being punished for that. And so they learn to inhibit, and that leads to anxiety later in life. They can become fixated, according to Freud, at that psychosocial stage. And later in life, they may have an oral fixation, so they may be anxious. And to sort of gratify that oral fixation, they may smoke a lot because that's the one way to gratify that oral fixation. Or they may overeat. As eating is a way to gratify that oral fixation, all stemming back from parents being too punitive with their infants, with their children early in life. So it's very important for parents to allow the young infant and toddler to express those impulses. Could also lead to faulty defense mechanisms by the ego, may overwhelm the child and lead to the development of GAD. But those defense mechanisms are most likely put in place because the id has not been gratified. The child has not expressed their id impulses appropriately. So as a parent, you need to allow the child to explore. And even if the child does some things that you may not approve of, like putting objects in their mouth as an infant, you have to realize that this is healthy. And it's actually healthy from an immunological perspective as well, because it's important for children to be exposed to germs early in life. And they've shown this in research looking at what is the rate of autoimmune disorders in the U.S., in Western societies like the U.S. versus, say, Africa. And in the U.S., people have a much higher rate of autoimmune disorders. And one of the hypotheses behind this is the cleanliness hypothesis. The cleanliness hypothesis is that if you're exposed to germs early in life, your immune system will adapt and you won't develop these autoimmune problems later in life. So you have to be exposed at an early age to germs. It's actually healthy. And in the U.S. and Western societies, we're actually too clean. And that's a risk factor for the development of autoimmune disorders. I mean, that's one risk factor. There's lots of other risk factors involved, right? There's even ethnic-based factors involved in the development of autoimmune disorders. So the bottom line, though, is let your child explore the world. Don't worry about germs early in life. Don't worry about bad habits early in life. Let the child express their innate impulses, explore the world, and they're less likely to A, have anxiety disorders later in life, and B, develop autoimmune disorders later in life as well. From the humanistic perspective, the Rogerian Carl Rogers approach, theorists propose that GAD arises when people stop looking and accepting themselves for who they are. And Rogers called this conditions of worth. I need to act and behave a certain way to get acceptance from my parents, and then later in life from my significant other. I need to pretend to be someone that I'm not. Because these people in my life, important people like parents and later on romantic relationships, romantic partners, they are not providing unconditional positive regard. Unconditional positive regard is acceptance, total acceptance. Your parents should totally accept you as a child, and then eventually, continue until you're an adult. You should be totally accepted. It's not that but your parents love you when you get good grades in school. That's a condition of worth. Getting good grades in school gets you attention from your parents. That's not unconditional positive regard. Unconditional positive regard is I love you no matter what. And Rogers would actually, rely on this type of therapy by establishing unconditional positive regard with his clients. So if you're not getting this kind of unconditional positive regard with your partner, then Rogers needs to establish this bond. And that's what I call like the hand-holding approach. You're good, you're perfect the way you are, you're a good person, things are going to be okay, you can grow from this. That's Rogers. Not challenging, very accepting and supportive. And he shows you genuineness and empathy. He understands you. I'm talking about Rogers. He understands his clients. He accepts his clients. And he's genuine when he talks to his clients. And that's very important under the humanistic perspective, is to show this unconditional positive regard and this have to have empathy and genuineness towards your clients. Because that is the basis for self-actualization, which is being the best you can be. If you don't show these things and you establish conditions of worth, that child eventually, as an adult, will grow up to have anxiety. And they might be very upset. They might have a conflicted relationship with their parents, because their parents haven't showed this unconditional positive regard. Their parents said, you need to do this for a career. Really? What good is that? How about give your child options and be encouraging? Not be authoritarian and telling your child exactly what they have to do. This is not the military. This is a parent-child relationship. So Rogers believed in acceptance and not challenging. On the other hand, the cognitive theorists, which involve Albert Ellis and Aaron Beck, believed in irrational assumptions. So they didn't believe in this unconditional positive regard. They believed that it all stemmed from what you were thinking. Even if you were not aware of what you thought, it's affecting you. And it's leading to anxiety and GAD. It could lead to other things other than GAD, but GAD is one possibility. So this whole idea that it's necessary to be loved or accepted by everyone, that's irrational. Why hold on to this? It's awful and catastrophic when things don't go right. Why? Why is it catastrophic? Why is it awful? If you look at it, it's not. There's nothing catastrophic or awful about it. No matter what you do, no matter what your failings are, no matter what the outcome is, It's never as catastrophic and awful as you think it is. Or another one, the situation is unsafe until proven safe. So this idea that everything is dangerous. That's one idea that can be cemented in your mind, and that can lead to an anxiety disorder. Everything is dangerous. That leads to avoidance. That exacerbates the anxiety, which leads to more avoidance. So these are negative automatic thoughts, which means that they just kind of intrude into your mind with very little of your own control. You may not even be aware of them unless you really reflect on what you were thinking and saying to yourself, because they happen really quickly. And you've been saying these things in the case of an anxiety disorder. I use you, but I mean the client has been saying these things to themselves for many years or decades. So to break that train of thought, that maladaptive train of thought, it's going to take time. It's not something that you can do in one session. And I think the problem with the cognitive approach and, you know, by extension, the cognitive behavioral approach is that people give up because they see this and they say it's too much work. I'd rather take a pill, or I have too much homework. Because with the cognitive approach and the behavioral approach, you're going to have homework and you're going to have to do it in order to improve. And most clients don't want to do the work. They want a quick fix. They want an easy fix. And they'll say, well, I'm paying you to be my therapist. Why don't you fix me? It doesn't work that way. You have to put your own effort into it. And it can take months, if not years, to break this negative chain of maladaptive thoughts. But it can be done. So it can be done through workbooking. There's an anxiety and phobia workbook by Edmund Bourne. It's quite excellent. It's a cognitive behavioral workbook, and the client has to go through exercises every week. And then you review with your therapist. So it's kind of a partnership. The exercises are for the cognitive problems, and then you have to do the other behavioral exercises like approach, the feared stimulus or feared situation. But GAD, a lot of it is cognitive, especially if you're a believer in Albert Ellis and Arendt Beck. This is not a hold your hand sort of approach. This is a challenge the client sort of approach. So Albert Ellis was challenging his clients. And if you do a YouTube search on Albert Ellis, you'll see that he's very challenging. He's not the hold your hand type of person. You'll see this with Carl Rogers. If you YouTube Carl Rogers and you YouTube Albert Ellis, you're going to see completely different styles. And for some people, they need to be challenged. For others, the challenging might be overwhelming, and then they retreat, and they don't come back. So it's important that you feel comfortable with whatever approach you're seeking out. But Ellis can be quite difficult to deal with. And Carl Rogers can be quite caring and sweet, but is that technique going to be effective with you? Some people need that. Other people need more of a push. Treatment, of course, challenge the maladaptive assumptions, these problematic thought patterns. Point out that they're irrational, suggest more appropriate assumptions, do homework exercises, and within a few months, you should see some improvement. Now, does that mean you're not going to have any anxiety? So if you have GAD, and you've had GAD for years, does that mean that you will no longer have GAD? No. You might have some residual anxiety. It's going to be much better, and you're going to be able to cope with it. And eventually, over time, the GAD should diminish. But does that mean you're cured? No, no cure. Now, could you do this with pharmacology, with drugs? Yes. But there's no cure with drugs either. So if you're looking for a permanent enhancement or diminishment of your problems, cognitive behavioral therapy is effective for anxiety, very effective. But it's not a quick fix. It's a much more permanent resolution than taking drugs. Taking drugs might get you jump started. So if you need to take an antidepressant and while you start cognitive behavioral therapy, that's fine. But once you get to do the therapy over a few months, you might start to try to cut down on the antidepressant and continue the therapy. Because if you're just relying on the drug, you might hit a few bumps on the road. It's not always a perfect solution to just take medication endlessly. Here's the rational mode of treatment. You have this activating event, which is a stressor. I asked Jackie out on a date. She said no. It's horrifying. You really think highly of Jackie? You say to yourself, Jackie rejected me. I'll never find love. This woman I love more than anyone ever in my life. And if I can't have her, if she rejected me, it's hopeless. I give up. What are the emotional consequences? You're depressed. You don't want to do anything. You're not going to look for another date because it's pointless. You'll never find love. This was the love of your life. She rejected you. And now you're stuck in that cycle. She rejected me. I'll never find love. So why bother? So I'm just going to give up and I'm just going to watch Netflix for weeks at a time. Or I'm going to drown it out by, having a couple drinks. Or I'm going to drown it out by, playing some video games. Or I'm going to drown it out by going online and, going on chat rooms, whatever. BSing with your friends or going out with your friends. I mean, that's not necessarily a bad idea, right? And I'm not saying that you can't do any of these things, but you don't want to just avoid the situation entirely. You want to regroup and then try again. But you need to change that irrational belief in order to do this. You need to say to yourself, well, Jackie rejected me, but there's so many other people that are probably even better than Jackie. And people like me. I'm a great catch. I'm intelligent. I'm physically attractive. I'm kind. I'm friendly. These things that probably are true. And even if they're not true, right? There's going to be other options than Jackie. But people get stuck. Or if they lose their job, they just give up. I'll never find another job. I'm done. I quit. Why look? What's the point? It's not, no one will want to hire me. What's the point? I'll never get another job, or I'll be working at a shitty job all my life. So I'll never get an education because it's not going to help me. And I'm never going to, make connections and go out and meet people and be assertive with regard to sending my resumes out or your CVs. It's easier just to stay in bed. I mean, it is. I mean, it's easier. I mean, I can't say that I've never been there. I mean, of course, we've all been there. I've been there. Where you're frustrated. I was looking for faculty jobs after graduating Rutgers, getting a PhD at Rutgers, and I couldn't find anything. And I'm sending out resumes, my CVs, and nothing. And I'm like, I don't know where to go with this. I keep sending them out, and no one's even asking me for an interview. And so what I did was I applied to other jobs, and I got a job in the insurance industry, looking at data, making decisions based on data, and looking at diagnoses. Do we send this person to the hospital? Do we not send this person to the hospital? What's the outcome? What's the most likely outcome? How much is it going to cost? I mean, look, insurance companies not a great place ethically to work because they're so greedy. But I said, let me try something different. and see what happens. And as I was working there, I continued to send out resumes, and I got an interview at BMCC, and I never heard of BMCC, but I said to myself, yeah, okay, I'm gonna, the interview was on a Saturday. I was working Monday to Friday, basically all day and all night. I was working crazy hours, and I knew that I didn't want to work a corporate job my whole life. Although the pay was good, it was like your whole life revolves around corporate. You have very little flexibility. It's stressful every day, and I had to like stop with this thought process that I'm never going to find a job and do something else. Change your focus. I changed my focus and took a job somewhere else, and then eventually I did find an academic job. And I'm the first one to say I was very lucky to do that. And I mean, I needed money, so I had to take another job. But I was very lucky to get this interview at BMCC, and I love working at BMCC. And I wouldn't want to go back to corporate ever, even if they pay me more money. But it took a lot of, okay, this isn't working. I got to try something else. I'm not incompetent. I'm not a bad, I'm going to get a job eventually. I had to get out of this kind of defeatist attitude to change my life in a positive manner. And then a little luck, but you make your own luck too. If you're going to sit in your room and watch Netflix or eat ice cream or do whatever, and you give up, you're not going to get lucky. Nothing's going to change. You're just going to be miserable. So it takes a little work, but if you feel stuck, that's the point at which you have to reach out and get help. And the help will get you out of this stuck condition. And a lot of people feel stuck. They feel stuck in a variety of ways. So it's very important to reach out. There is help available. There's help at BMCC available for free. So it's not like you need a lot of money to get help. But I always encourage people, if you feel like you're stuck, reach out and get help. You're not stuck. It's just your mind is telling you you're stuck, but that's not logical. It's not rational. And a lot of that's depression. A lot of that's anxiety. A lot of that's fear of the unknown. You got to get out of that cycle, out of that mindset. Rational emotive therapy is one way out. I'm not saying it's the only way out, but it is one way out that has been shown to be effective. Biological treatments for GAD, anti-anxiety drug therapy, barbiturates. Those were first generation sedative hypnotic sleeping pills. Not a good solution. People overdosed on barbiturates. They died. When you mix them with alcohol, you can overdose. So you're not going to get barbiturates anytime soon. They're very dangerous drugs. Benzodiazepines are the current treatment. Sometimes they're called benzos. Examples of these are Xanax, Ativan, Klonopin, Valium, Librium. I mean, there's a whole family of those. Those are very common ones. Some of them have a shorter half-life, like Ativan, which is useful for, say, a panic attack, because you want the panic to resolve quickly. So Ativan or Xanax. Ativan's even faster than Xanax, but those two would resolve the panic attack pretty quickly. Other ones are longer lasting, like Klonopin, where you have to take them twice a day, and they're very long lasting. So maybe they're not as effective once you're having full-blown panic, but if you take them on a preventative basis, they do reduce anxiety. The only problem with this is that once you stop taking these drugs, you're going to have high levels of anxiety again. And let's say you're doing some kind of exposure therapy with benzos. If those benzos are of a certain dosage, that means they're not the minimum dosage. And you're doing behavioral exposure therapy to treat your phobia or some problem with avoidance you have or social anxiety. Those behavioral therapies are not going to be long lasting while you're taking the benzo. And the reason for that is this idea that you need to experience some levels of anxiety to desensitize yourself from the anxiety. And if you're suppressing the anxiety too much with drugs like the benzodiazepines, you're not going to experience those levels of anxiety, and you're not going to be able to desensitize. And then when you stop taking them, you're going to still have the anxiety and the phobia response. So recently, over the last couple of decades, there's been a bigger push towards antidepressants for anxiety. And what they've shown is if you take a moderate dose of an antidepressant, you can get the benefits of desensitization of a phobia or of a fear. And then when you stop the drug, you still carry the benefits of that behavioral desensitization process. And there's also antipsychotic meds, but those are very, very strong. That would require like intense anxiety, or the antidepressant's not working and you want the antidepressant to work better. You can take an antipsychotic with it to boost the effect of the antidepressant. But the antidepressant by itself generally works pretty well for phobia, anxiety, social anxiety, generalized anxiety, pretty much all the anxieties. And the other benefit is it treats depression as well. So you need to take it for about 6 weeks to get the maximum benefit. So it's not something that's quickly acting like the benzodiazepines. But overall, this is the preference, is to push people onto antidepressants and off of benzodiazepines. Other kinds of biological treatments include relaxation training, meditation, yoga, progressive muscle relaxation, where you tense each muscle group of your body and then relax, and then you couple that with deep breathing exercises. These are best used when combined with cognitive therapy or biofeedback. Biofeedback is basically when you're hooked up to this machine and it monitors your heart rate and your blood pressure, and then it like beeps when your heart rate goes above a certain level. It starts beeping, so it lets you know you need to relax. So it can be effective if you don't try too hard. By that I mean you can't get worried every time you hear a beep. You can't go like panicking. You hear the beep because then the beep's going to get louder and louder, and it's going to do the opposite. You need to use that beep as a feedback mechanism to slow yourself down with the deep breathing exercises or the muscle relaxation or the meditation. Meditation is very effective. I've been studying it for years now. I've done it for years. It's really can really change your daily life if you start practicing on a regular basis. So let's move over to phobias now. Phobias derive from the Greek word for fear, and it's persistent and unreasonable fears of particular objects, activity, or situation. So phobia is a targeted fear, right? Fear is targeted. So the phobia is targeted to one thing or a series of related things, objects, or situations. Fear is a normal and common experience, but phobias are much different. Phobias are much more intense than just, being afraid of heights. You might be somewhat afraid of heights, and you don't like being like climbing up like ladders and being on high floors and looking out the windows on high floors, but you'll do it. It's not like you're going to rearrange your entire life to avoid it. That's just a normal fear. A phobia means you will avoid the situation or the object at all costs. It is so intense, you will do anything to avoid it. You will run in the opposite direction. You will have nothing to do with heights, with dogs, with whatever your target phobia is. So avoidance is really driving the phobia, and this interferes with your life. So maybe you can't, get on planes because you're afraid of heights or you're afraid of enclosed spaces. And because you can't get on planes, you can't take certain jobs, you can't go on certain vacations, and that's making you feel terribly. I mean, that's impacting your life and it's decreasing the enjoyment in your life. So once you're avoiding and it's leading to a problem with functioning, it becomes a phobia, and it can be treated. Some of them are easier to treat than others, but they can all be treated with the appropriate help. Now, there are two broader kinds of phobias. You have social anxiety disorder and you have agoraphobia. Social anxiety disorder is an intense fear of a social situation like public speaking or public eating or even using public restrooms. Those are all social anxieties. Agoraphobia is a really difficult phobia to treat, and it's fear of leaving your safe haven or your safe spot. And what that means is, technically, it means fear of the marketplace in Greek, but that's a little bit dated in terms of terminology. What it basically means is you're comfortable in your house, that's your safe spot, and every time you leave your house, you're more and more uncomfortable going places. So you avoid them. And usually it's all based on panic attacks. So a panic attack triggers the avoidance, and that's how you develop agoraphobia. But those are much broader phobias, and as a result, they're more difficult to treat. If the phobia is to one specific object or situation, it becomes a simple phobia, and that's the easiest to treat, the fastest to resolve. So simple or specific phobia is a fear of a specific object or situation. And when you're exposed to that object or situation, you experience immediate fear, intense fear, and you want to avoid it. And this avoidance significantly causes distress or impairment in your daily function. It must last at least 6 months. So it could be a specific animals, specific insects, heights, enclosed spaces, thunderstorms, or even blood phobia, which is really occurs, the opposite response occurs in your body than normal phobia. So normal phobia will increase your heart rate and blood pressure. The blood phobia, for whatever reason, will decrease your heart rate and blood pressure to the point where you can pass out. So it's kind of the opposite of the other phobias. So someone with a blood phobia, the best way to avoid passing out is don't look, or avoid needles, avoid everything that involves drawing blood. There are some people with severe blood phobia, they get a little cut on their hand, they see blood, and they pass out. So that has to be addressed. That has to be slowly desensitized. It can work. It's just a little different than how the rest of the phobias work. The rest of the phobias speed you up, elevate your blood pressure, and the blood phobia slows you down and drops your blood pressure. Each year, close to 9% of the people in the U.S. have symptoms of specific phobia. That's a large portion of the U.S. It's a huge portion that have specific phobia. Something around 35 million people. Many can suffer from multiple phobias. And women, as always, outnumber men by at least 2 to 1. And the vast majority of people with phobia just do not seek treatment, they just avoid. And you'll see the video that I have posted to Blackboard on specific phobia and how it can really be traumatic. I mean, it's a video is kind of funny, but at the same time, you know that the guy is suffering so badly from it. So I would encourage you to watch that video. The fear of the dogs and fear of parks because of the dog. And he had a trauma in early childhood. And the guy is really suffering. And it's interfering in his life, and he feels terrible about it. What causes specific phobias? Classical conditioning. You can see this with the case of little Albert. Little Albert was the experiment done by John Watson where he gave little Albert the white bunny and then blew like a really loud noise into his ears. And it was very distressing because babies hear loud noise, they get upset. And so every time he gave the bunny to the baby, he paired it up with a aversive stimulus, a loud noise, and eventually The baby would then fear the bunny because the baby assumed that the loud noise was coming. And there was some generalization where the baby not only feared the bunny, but feared anything that was like soft and white. And that's a stimulus generalization. So it can happen with phobias where you fear the specific target, but then you can fear things that are similar to it. Now, that's very unethical what John Watson did. I mean, he classically conditioned a baby to be afraid of a bunny. So that's extremely unethical to do that. So you're creating a phobia in a toddler, but he showed that it happened only after a few trials. So in one hand, it's important for us to understand how phobias develop. On the other hand, it's really unethical and it's something that would never be done today. Phobias can also be developed through modeling, so you don't have to be classically conditioned. You can develop it through watching somebody else have a problem. In the case of the video that you should watch that's on Blackboard, the guy that developed a phobia because he saw his friend when he was young get viciously attacked by a dog. So the dog didn't attack him, but by seeing his friend get viciously attacked, he developed a phobia through imitation, through modeling. So you can develop the phobia directly or through modeling. And the phobias are maintained through avoidance. Once you approach the phobic stimulus, you start breaking the conditioning process, right? That leads to extinction, and once extinction occurs, that's the end of the phobia. The problem with phobias are that fears, and phobia is a fear, is one trial learning, which means you only have to have one bad experience to classically condition phobias. That one bad experience in any time in your life, especially early in life, can make you afraid of some object or situation the whole rest of your life. And then you strengthen the phobia through avoidance. So it only takes one negative experience to condition the phobia or to model the phobia, but it takes many, many approaches and acts of desensitization, right? Approaching the feared stimulus. Many, many iterations or trials of that before you extinguish the fear. So it's easy to acquire and slow to extinguish, which makes it a problem. Avoidance is the easiest solution for people, and they may avoid their whole life. They may say, okay, I have this problem, but I just avoid, and therefore I don't have to worry about it. And I live my life by just avoiding. Now, if you're avoiding something that you can easily avoid, and that's not going to interfere in your life, then okay, I guess. If you're comfortable with that, it doesn't ruin your life, it's okay. But if you're avoiding something that's basically bringing down your quality of life, and something that clearly distresses you, then it's a phobia that needs to be addressed. Some phobias are much more common than others due to an evolutionary principle, and that's what's called biological preparedness. So human beings are more prepared to acquire some phobias than others. For example, fear of snakes, fear of spiders are very easy to develop, whereas meat in houses are much more difficult because there's no survival element with a fear of meat or a fear of houses. There's a definite survival element with a fear of snakes. Now, you see a snake, you get out of there because the snake could be poisonous, unless you can identify the snake and know that it's not poisonous. And maybe you can, but your genes are wired to avoid the snakes. You want no part of the snake because snakes can be dangerous. Snakes can inject you with poison, and if you're not treated immediately for that poison, you could die. So there's an evolutionary advantage to fearing snakes. And the same thing with spiders. Spider bite can be poisonous. Spider bite can kill you. So, evolutionary wise, it's important to avoid it. So that's why snakes and spiders are very common phobias. Can you defeat or eliminate intense fear or phobia of snakes and spiders? Yes, you can. But once again, I wouldn't just approach any snake. If the snake is not poisonous, then it's something that you can approach. But if the snake is poisonous, or the snake could possibly kill you if you don't know how to handle the snake well, it's probably best to avoid it. And you can pretty much live your life avoiding snakes and spiders for the most part. You see a spider, you kill it, or you go in the opposite direction. People do it all the time. You see a snake, you go in the opposite direction, or you call someone to remove it. Meat in houses, these are much more complex phobias. I mean, they're not easily established, and they're pretty easy to extinguish because you're not biologically prepared to fear these objects. You're also biologically prepared to fear certain foods. So if you eat food and you get very sick from it, you will make that connection. You will establish that link. And you might not necessarily have a phobia, but you'll have an avoidance of that food. And that's done really quickly. So you only have to have one bad experience with food poisoning to never want to eat that food again in your life. And from a biological or evolutionary point of view, that makes sense because the food might kill you. So if you're getting food poisoning, it's going to save your life. If you eat that food again, next time you might die. Now, look, you're probably not going to die of food poisoning. Even with severe dehydration, you can go to a hospital, they'll get you through it. But our ancestors didn't have the option of getting an IV fluids in a hospital. So in their cases, food poisoning could really be deadly. How do you treat specific phobias? Systematic desensitization. This was a technique developed by Joseph Volpe. You start doing relaxation exercises like either meditation or deep breathing exercises, and then you create a fear hierarchy. So what are you very afraid of? That's at the top of the fear hierarchy. And what's the least object or situation you're afraid of? So that fear hierarchy could be something like looking at a picture. Let's say you're afraid of spiders. You have an intense phobia of spiders. That means you run in the opposite direction whenever you see a spider. You might start off with pictures. So you go on the internet and you look at a picture of a spider. And then you check to see how severe the anxiety response is. And then you look at a bigger spider. And you do your deep breathing exercises or your relaxation exercises and deal with a bigger spider. And you're okay with that? Now you look at a tarantula. And then once again, you can do that, your deep breathing exercises. You can even do this with virtual reality too. Because now they're using virtual reality for phobias. And it can be somewhat effective. I mean, I'm a big fan of virtual reality for treating anxiety. I've seen it work with people. So it's quite interesting. But if you can't do virtual reality, start with pictures. Now, once you've done all those pictures, or if you don't have pictures, imagine yourself, imagine a spider across the room. Now, imagine that spider walking closer towards you. Once you're comfortable with these images or imagination, you can start doing what's called in vivo. In vivo is the real thing, live. So now, you're not just looking at pictures or imagining a spider walking towards you. I'm bringing the spider into a room. I'm putting it on the other side of the room, and you're going to slowly watch that spider walk towards you, or you're going to slowly approach the spider from the other side of the room. Now, this is going to elicit considerable more fear and anxiety, right? This is going to be a huge exacerbate the fear in the phobic situation, and then you're going to gradually approach that feared stimulus. And this is not going to happen 1, 2, 3. This may take a while for you to work up to these stages. But you're going to keep doing those relaxation exercises and the deep breathing exercises or the meditations while you're approaching the feared stimulus. And the goal is to eventually get to that feared stimulus Maybe you get to the spider and maybe you touch the spider, maybe you pick up the spider. Now, that could be the highest item on your fear hierarchy, picking up the spider. That might terrify you, but eventually you'll get there. I've seen this done with tarantulas, where the person had to approach the tarantula. So, and the tarantula was gigantic. I saw the tarantula and I was like, okay. I didn't want to be in the room either. I don't have a fear of spiders, but I kind of didn't want to be in the room with the tarantula. And I certainly wouldn't want to pick it up. But eventually, they got to the point where they could pick up the tarantula. And that, so it's like baby steps towards the end goal. And that may take weeks, it may take months, depending on how strong the phobia is. It's not something that's going to be done in one day. You may see the end product in one day, but the person has been working on this for weeks, if not months. Now, that is in vivo desensitization that I just talked about. So the gradual approaching of the feared stimulus is in vivo desensitization. That's in real life desensitization. If you don't believe in desensitization, I'm a strong believer in desensitization. I think it works great. But there are some clinicians that think maybe it's not ideal. Maybe you can do it faster. And this is where the problem happens, in my opinion. Because they engage in something called flooding, which I think is just awful. And if you're dealing with the wrong client, the client will be traumatized, will leave, and never come back. Because here you're doing it not gradually. So you're not gradually approaching the feared stimulus. You're forcing the non-gradual exposure. So you're basically dumping the phobia on them all at once. And the way to look at this is if you ever heard of a show called Fear Factor, that used to be on TV. People had to be like exposed to like rats, spiders, snakes, and they basically just like threw them in a pit of like snakes. So if they were afraid of snakes, throw them in a pit full of snakes. That was like what Fear Factor was about. Fear Factor is flooding. If you have someone with an extreme phobia of spiders, and now you dump a bucket full of large spiders on them, how do you think they're going to respond? Well, the clinicians that believe in flooding say, okay, you're going to feel terrible at first. The anxiety is going to be through the roof at the beginning, but eventually it's going to come down because anxiety has a limit. Physiologically, there's only so much anxiety we can have, and you're maxing out when I dump the barrel of spiders on you when you're terrified of spiders. I'm maxing out your anxiety. So I'm basically maxing out the phobia right there. And then eventually, you'll adapt. Your heart rate will go down, your blood pressure will go down, and you're not going to have that extreme anxiety after a while because there's only so much energy to expend towards anxiety, and eventually it will drop and you'll be okay with it. So you'll see that, oh, I'm sitting with a bucket of spiders on me and I'm not panicking. It stopped. At the beginning, I was terrified and now I feel okay. And so they're saying this is like basically all at once. It's like the shotgun approach to treating a phobia. And people that believe in flooding, flooding is very controversial. I do not believe in flooding, but if people believe in flooding, they think that it works more effectively than desensitization. Because desensitization, you're taking very small steps over time. So A, it's very slow, and B, even if you do reach the top of the hierarchy of your feared stimuli, are you going to be okay now? Like, now that you picked up the spider, are you going to be okay if I dump a bunch of spiders on you? Probably not. So you're treating the phobia, but you're treating it in a very slow manner, and maybe you're not totally eradicating it right away. But with flooding, you are, if the person can deal with it. Or you can make your client run away, be traumatized, have to take, benzos to calm down, have nightmares of it, and you're setting them back, in my opinion. So it is very controversial, flooding. You may also try modeling. So the therapist will then confront the feared object while the person with the phobia observes. Now, this is not totally effective because you could understand that the therapist is confronting the object. The object's not dangerous to the therapist, but it's still dangerous to you. But it's one way of helping you along the process. If you see the therapist approach the feared person or object situation, then you can model that behavior. You know it's safe. The therapist did it. Now you can imitate. It's not the same as doing it yourself, but it is something that can go along with the imagery phase, right? Imagine this happening. Now you're seeing your therapist do it, so it's better than imagining it. Now you have to do it yourself. As I said before, virtual reality is becoming a very good exposure tool, and I much prefer desensitization of flooding. I think flooding can work. I'm not going to say flooding doesn't work. It can. It's just really intense. It might be too much for people. And you can have negative outcomes with flooding. So you have to be very careful who you're doing flooding with. And most therapists are not using flooding these days. They're using desensitization. Very few people are using flooding. But like I said, flooding can work with the right person. Now, agoraphobia. Agoraphobia is a very complex phobia. It's not like simple phobia or specific phobia. Simple and specific are the same thing. They're your basic phobia, right? Agoraphobia is much more complex because the fear now is a fear of any public place or situation where escape is difficult. And agoraphobia is almost entirely based on panic attacks. A panic attack is basically a mistake that your central nervous system is involved with. So your central nervous system makes an error, and your heart rate increases, and your blood pressure increases, and your muscles tighten up. So it's basically the fight or flight response, the adrenaline response, but it's inappropriate. It's too nothing. You can have a panic attack at your job. You have a panic attack at school. Nothing is really setting it off, right? Your heart's racing, and you're like, "What's going on here?" And if you never had a panic attack before, you might think it's a heart attack. You might think it's a stroke. You might think you can't breathe. Something's wrong. You're having a severe reaction, severe asthma or something like that. But then they take you to the hospital and they run all the tests and they say, you're okay. You had a panic attack. Happens very frequently in hospitals, in emergency rooms. People come in, think they're having a heart attack or a stroke, and they have a panic attack. Now, that's not to say that you should not go to the hospital. So if you're having this for the first time, don't say to yourself, it's a panic attack, I'm okay. You want to get that checked out. So you're probably better off going to the emergency room. Make sure it's not your heart. Make sure it's not, your brain. And then once you're cleared, then now you know it's a panic attack. And now if you have a future panic attack, you know you don't have to go to the hospital, and that's part of it. But it's so scary the first time you've had it that you may want to go to the hospital immediately. Because you don't know, you think you're dying. I mean, you could even have dissociative symptoms. So you may feel like you're detached from your body, or you may be floating in the air, looking at yourself down, on the ground. So there can be a dissociative element too in some cases. And this fear, this panic attack, makes you so afraid to go places. Because if you've had the panic attack in the supermarket, you do not want to go to the supermarket. If you've had the panic attack in the classroom, you do not want to go to class. If you've had it driving a car, you don't want to drive a car. In the subway, you avoid the subway. So eventually, in some people, you avoid everything. And now you're stuck at home. To the point where if you go outside your home, You become afraid of a panic attack and your anxiety goes way up. And you're just afraid to leave the home. Because what if I get stuck here and I have a panic attack? What will happen? Well, in the back of your head, you may say, you know, nothing. I'm going to feel uncomfortable and then everything's going to be okay. But when you're going through the experience of a panic attack, it's a different rationale. You know, it's very easy to say, oh, the panic attack, nothing's going to happen. You know, it's a false alarm. That sounds logical, but in your head, you still have those illogical, automatic negative thoughts like, what if it is a heart attack? What if I get stuck? What if I can't get home? What if I pass out? What if I make a fool out of myself? What if I have chest pain and I end up falling on the floor? What if they got it wrong when I went to the hospital? They told me it was a panic attack. What if they're wrong? Those are negative cognitions. Those are illogical cognitions that can then exacerbate the anxiety and then increase the avoidance to the point where you're avoiding everything. You're avoiding life, basically. So it's kind of like being in the pandemic full time for your entire life, you know, without the mask. But you can't leave the house. You're afraid to leave the house. It's kind of like that. So imagine how miserable you are with the pandemic and then sort of multiply that misery because now you're dealing with, I can't go anywhere. Can't leave my house or my apartment. Can't go to your job. Can't do anything. You can't function. So it causes significant distress or impairment. It typically develops for the first time in your 20s or 30s. So it happens relatively early in life, which is also a sign that it's not a stroke. It's not a heart attack because you have very few strokes and heart attacks in people in their 20s. I mean, not that it can't happen, but it's really rare. So this increased heart rate, chest pain, difficulty breathing, um, all this stuff is probably just panic. But get yourself examined first. Make sure it's not pheochromocytoma, adrenal gland tumor, even though that's insanely rare. It can happen. I know one woman that had this. And it was quite interesting. I asked her a lot about it because I was like, you had pheochromocytoma? I said, that's fascinating. That's so rare. I've never met someone with pheochromocytoma before. And I guess I humored her a bit with this, but she was like, yeah, it was dangerous. I almost died. I was like, oh, I'm interested in it. She's afraid she's going to die from it, so not the best conversation there. But nevertheless, it's probably not that. It's most likely panic rather than heart attack, rather than adrenal gland tumor, um, rather than thyroid storm, something like that, right? It must last at least 6 months, and you avoid all situations in which you feel that you'll have a panic attack. Obviously, the explanation is you're afraid of panic attacks, so you avoid. It's like avoiding the phobic stimulus, except that the phobic stimulus is everywhere, except your house. You feel safe in your house. There have been really rare cases where someone was only safe in their room, where they slept in. But most of the time, you're pretty safe in your house. You can walk around the house, you feel fine. The moment you open your door, your house or apartment, I should say. The moment you open the door and you walk out, now the anxiety starts. Now, maybe you can walk a little bit. Maybe you can leave your house for a short time or a short distance. But the farther you are away from your house or apartment, the higher the anxiety is. And the more you want to get back right away. So if you have panic attacks and you're worried about those panic attacks and it's causing this agoraphobia, the disorder is agoraphobia and the diagnosis, I should say, not the disorder. The diagnosis is agoraphobia and panic disorder. If you have a panic attack and you're not worried about it and it's very infrequent, then it's just diagnosed as a panic attack. There are plenty of people that have rare panic attacks and they deal with them. They put them behind them and that's it. They had a panic attack, they had a couple panic attacks, and they dealt with it and it went away. They didn't develop agoraphobia. They weren't worried about having future attacks because if you're worried about having future attacks, you now have panic disorder. And panic disorder and agoraphobia go together almost all the time. It's very rare to have panic disorder without agoraphobia. Because by definition, panic disorder means you're overly concerned with having a panic attack. And that's what's causing you to avoid. So that's causing the agoraphobia. And the treatment is the same as treating simple phobia, but usually you want medication also with this. So the treatment is exposure therapy, support groups can help, especially if they're online. There is some home-based self-help. There have been cases where therapists will visit the home. They don't always do this, but in special cases of agoraphobia, a therapist can visit, a clinician can visit the home or the apartment or wherever you live and help you start your therapy. And the exposure therapy will be, okay, let's take a walk outside. Let's see how far we can get before you want to turn around and go back. And then you gradually increase the distance. If you have trouble at the supermarket, you're afraid of the supermarket, okay, go stand in line in the supermarket for 2 minutes, to start. Okay, now leave. Next time you go back, let's make it 4 minutes or 3 minutes, depending on how the first time went. And now you're just increasing very gradually the amount of time in the supermarket, the amount of time in the classroom, the amount of time in the car driving, the distance driven in the car. So you're doing it baby steps. But it's much more complicated than having like a specific phobia, because specific phobia you can avoid, right? And if you want to approach it, you can desensitize slowly. It's not going to like ruin your life though. You could be working on desensitizing the specific phobia and still have a relatively normal life. Whereas if you have agoraphobia, you can't have a relatively normal life before treatment or during the treatment because you can't go anywhere. You're not going to hold a job unless you work from home. So the pandemics are great for agoraphobics because this justifies them staying in. Or actually, I shouldn't say that. I mean, the pandemic's probably not good for agoraphobics because it justifies their reasons for staying inside. They see the world as a dangerous place normally, and with the pandemic, they see the world as an especially dangerous place. So I won't say that the pandemic is good for anybody with an anxiety disorder. There have been reports of people saying they felt better during the pandemic than before the pandemic. I take that with a grain of salt. The vast majority of people feel much worse, and the rates of mental illness have increased. So I can see this just reinforcing the idea that the environment is dangerous. But desensitization is the treatment, and then pharmacologically, antidepressants. You can try benzodiazepines to stop the panic attack. The problem with taking the benzodiazepines to stop the panic attack again is that the desensitization will not work when you're taking a certain higher doses of the anti-anxiety drug, of the benzos. So you would need to take a very low dose of the benzodiazepine to desensitize yourself. And that kind of defeats the purpose of even taking it because you feel like you're going to die. And if you take a very low dose, it's not going to do much. But that's the whole basis of desensitization. You need to feel that anxiety. You need to feel the anxiety response to desensitize. Now, with an antidepressant, you're going to feel that. You're going to feel the anxiety, but it's going to be less. Or in some cases, the antidepressant will stop the panic attacks. And once you stop the panic attacks, you're going to desensitize. Because you're going to go out these different places and you're going to be like, I don't have a panic attack. So I feel okay to go places. And then you will just naturally desensitize yourself. Will the panic attack come back when you stop taking the antidepressant? That's unknown. Can for some people. Other people can get off the antidepressant slowly and not have a rebound of anxiety or panic. But that's generally, with all these anxiety disorders, the preference is if you need to take a drug, it's best to take the antidepressant, the SSRI antidepressant. The tricyclics can be used. These are the old pills from the 60s, the tricyclic antidepressants. They can be used, like Tofranol can be used for panic. It's a tricyclic. It can be somewhat effective for panic attacks. The problem with these tricyclic antidepressants is they hit the histamine receptor site, so it makes you tired. Like it's like you're taking Benadryl. It's the same kind of same kind of effect. It hits the histamine receptor site, so you're getting that Benadryl-like drowsiness, which is why they're supposed to be taken at night to help you sleep. But if you're taking them during the day, you're going to be really drowsy with some of these tricyclic antidepressants. So that's the main treatment: desensitization and drugs, antidepressants, SSRI drugs, which are selective serotonin reuptake inhibitors. So they basically increase serotonin at the synapse. And you can also take I guess you can, if you want, take SNRIs, serotonin norepinephrine reuptake inhibitors. These drugs, though, increase norepinephrine and they might increase your anxiety. So it's probably best to take SSRIs like Paxil or Lexapro, because those tend to be more sedating, whereas something like Prozac tends to be more activating, may not work well for someone with anxiety. But they're very effective drugs. Can you take them your whole life? Of course. The side effects are minimal, mostly weight gain, sometimes insomnia, sometimes nausea, diarrhea, vomiting, right? Because they do tend to affect the serotonin in the GI tract. But those are mostly tolerable side effects, and they decrease over time. The tricyclic antidepressants have more side effects, and the issues with those side effects are the most concerning issue is a heart arrhythmia. So basically the QT interval. So basically the time between your heart pumping blood and then repolarizing and getting ready to pump again, that time period, that time interval gets increased. And in certain cases, that prolonged interval, what's called the QT interval, can lead to sudden cardiac death. And you've seen this in famous cases like Hank Gathers, who was a college basketball player for Loyola Marymount. He died on the court from undiagnosed long QT syndrome. And also the other basketball player, Reggie Lewis, who played for the Celtics in the 90s, had low QT syndrome. He died of cardiac arrest on the court. So something similar could happen with tricyclics. So if you have any kind of history of heart issues or you have any arrhythmias, then you would have to be monitored for changes with just an EKG. So they can give you either a mobile EKG, the Holter monitor, they put it on your chest, you wear it for 24 hours and they look at your heart rate. They look at your heartbeat for 24 hours, or they may give you a stress test, put you on a treadmill, or give you an injection to speed up your heart rate, and then look to see if there's changes in the heart rhythm. But for the vast majority of people, that's not a concern. I just mention it because it can be, a lethal side effect in very rare cases. For the most part, SSRIs are the way to go. And we'll talk more about that when we get to depression. You can also develop social anxiety disorder from everyday life events. Could be something that happened early in life, rejection in some way. Um, and social anxiety disorder can be fairly benign, like fear of public speaking is really common. It's not going to impact your life too much. I mean, it may impact your life if you're by profession, you have to go around speaking before audiences, but most people can live a normal life with just fear of public speaking. And there's plenty of support groups for that. And most people have a degree of this until they get used to it. Some people are just disabled, though, from public speaking, and they can't do it at all. If that's interfering in your life, that can be treated. Other social anxieties could be fear of eating in front of people, fear of writing in front of people, so they won't sign their name if other people are around or someone's looking at them. They won't eat if someone's around because they think they're being looked at, they're being examined while they eat. Makes them feel very uncomfortable. So they may not even go out to eat because they're terrified. They want to eat at home. Fear of public restrooms, so they don't want to use the bathroom in public if other people are around because they're being monitored. This can lead to self-esteem issues. It can lead to chronic avoidance, which can affect quality of life, which leads to significant distress or impairment. It has to last at least 6 months or more. It must impair you or cause you significant distress. You must avoid the feared situation. This can even be dating anxiety. So you're unwilling to go on dates because you're so anxious that you just don't want any part of that. You're afraid of dating. That can definitely cause you distress or impairment. You know, so they're speaking in public. Most people can get by that. I'm not saying it's not a problem, but fear of dating, fear of eating in public, fear of using public restrooms, these are much more invasive issues and potentially can decrease your quality of life a lot more. What causes social anxiety? Unrealistically high social standards. You need to perform perfectly in front of other people. You view themselves as unattractive social beings. They're unskilled or inadequate. They believe they're in danger of behaving incompetently in social situations. They feel something terrible is going to happen in social situations, or they have no control of their anxiety in social situations. So a lot of it's fear of negative evaluation, your fear of being judged negatively by other people. If you have high fear of negative evaluation, you're more likely to have social anxiety disorder. Treatments involve behavioral exposure. So if you're afraid of public speaking, start going in front of a small group of people and then build it up. Maybe a short time talking and then increase the length of talking. If you're afraid of eating in front of people, you need to start, with maybe one or two people, and you have a meal with one or two people and nobody else around. And then start building that up gradually. Same thing with public restrooms. Be by yourself if possible first, and then start increasing gradually, other people. It can be tricky because we don't always control how many people are around in social situations. So it can be somewhat difficult to treat um, using desensitization. You can also treat with increasing social skills, so assertiveness training. Maybe you just need a little more confidence to go out and talk to people, and then the social phobia will diminish. If you view yourself positively, if you increase your self-esteem. Or maybe you're just terrible dating, and you just engage in behavior that turns people off, and you need to change it. That could be social skills training geared towards dating, very gradually. Change some behaviors, try it out. Rejection is going to happen, and you got to try to get over that. But you have people that have severe social anxiety in some cases, and they'll just avoid everything. They'll avoid going out in public. They'll avoid, dating. So they don't have agoraphobia because they'll go by themselves, but they don't want to be around other people because they feel like they're going to be rejected. And they may have shut themselves down and isolated themselves. And then it becomes challenging because this could be going on for years, if not decades. You know, decades. And now you have to deal with this. If someone's older and they haven't dated for 20 years, they're probably terrified. It's going to be hard to convince them to start. They may have gotten rejected. They feel inferior. It makes them very nervous, so they avoid it. And now it's 20 years. They're getting older, and they haven't had the proper experiences, and that makes it even harder for them to be effective in these social situations like dating. And it's not like you can dial up someone and say, okay, this attractive person that you wish you could go out with, they're going to go out with you. You just can't do that sort of thing, right? So you have to work on the social skills training. You have to work on very gradually getting the person to approach, say, a potential date, and then do it really slowly and sort of help them build up, help them become competent in this social interaction. And if it's still very severe, if they're still having very severe anxiety, even though you're working on developing their social skills and helping them become more assertive, and you're doing this in very small steps, you may add some antidepressant to it. And that probably will help a little bit decrease the overall levels of anxiety. And as I mentioned, panic disorder before, which goes with agoraphobia, is basically a fear of having panic attacks repeatedly and not be able to control them. So you have to have a month of continual concerns about having panic attacks and dysfunctional behavior like avoidance. And that leads to agoraphobia, obviously. You're constantly afraid of having a panic attack. You continuously avoid situations, and now you're agoraphobic. So that's why panic disorder basically leads to agoraphobia in most cases. Now, you could have a case of agoraphobia in someone without panic disorder, but it's rare. It mostly occurs with panic disorder. Mostly occurs with panic disorder. Very rarely you have it separate. The person is just not, your client is not just agoraphobic for no reason. They're not born agoraphobic. They've had some negative event, and it probably involves a panic attack. Now, whether that panic attack is some kind of dysfunction in the brain, it's benign. It's not like a tumor or anything, but it's some kind of fault, faultiness in your brain that regulates the fear response, which we don't know exactly what it is yet. Or it could be drug induced. I mean, that happens very commonly. You're taking cocaine, or even you're smoking marijuana. Marijuana can trigger a panic attack. Cocaine can definitely trigger a panic attack. Methamphetamine, panic attack. MDMA, panic attacks. These are all stimulants. I mean, cocaine is a mild, I mean, not cocaine. Marijuana is a mild hallucinogen, technically, but there can be a trigger of a panic attack with marijuana use, and that could lead to panic disorder, even if you stop the marijuana use. So drugs can play a part in this as well. But now, that doesn't mean that you're going to get a panic attack from using certain drugs, but you can. It depends on your genetics, it depends on your environment, it depends on a lot of things, right? Some people can get a panic attack, and it can lead to panic disorder and agoraphobia. And if they quit using the drug, they're not going to have panic attacks anymore, but it may take a while for them to extinguish all the fear associated with the panic attacks that they were once having. More than a quarter of people have one or more panic attacks at some point in their lives. And most people that have this occasional panic attack brush it off and they go back to normal. But if you have repeated panic attacks, you're more likely to get panic disorder. And you'll worry consistently about having an attack, or you start to avoid because you're afraid of a future attack. And that's where the agoraphobia kicks in. And as I mentioned, it's associated with agoraphobia. And this is sort of a new sort of link, obvious, but it's a pretty obvious link because anyone that's had panic attacks at any point in time realizes they're severe. We don't know exactly what causes them, and it's not inconceivable that someone would try to avoid a situation which triggered a panic attack. So panic disorder often is accompanied by agoraphobia. What are the biological factors that contribute to panic disorder? Norepinephrine. So research suggests that panic is related to changes in norepinephrine in the locus coeruleus. Why that happens is still not known. We really don't know exactly what's going on, but there is an increase in norepinephrine, and it may sort of also involve the amygdala. So there may be some kind of biological or genetic deficit with your locus coeruleus or your amygdala. It's not known exactly what it is yet. It's correlational data. It's based off of brain imaging. But there's no way to trigger, there's no direct treatment to stop this. There is, giving antidepressants can alleviate panic attacks. By increasing serotonin, somehow that can maybe stop or neutralize this norepinephrine effect. But this is also another reason why you don't necessarily want to take the SNRI drugs, the serotonin norepinephrine reuptake inhibitor drugs for panic, because they increase norepinephrine. So they're very effective for depression, but they may cause increase in anxiety. And the same with most tricyclic antidepressants, with the exception of tofranol or empyramine. As I mentioned previously, drug therapy is effective. Improvements require tricyclics like tofranol or Paxil, Zoloft, Lexapro. Those are probably the best treatments. I would say start with the Paxil, Zoloft, Lexapro, SSRI drugs. And if they don't work, you can try tofranol, which is a tricyclic that's been approved for panic. Benzodiazepines are really the last result. Ativan is very effective for stopping a panic attack, but it's not going to prevent a panic attack. And if you get used to popping Ativan every time you have a panic attack, your body's going to be conditioned to it. You're going to build tolerance, and Ativan's not going to work anymore. So Ativan would be for a very rare event. Klonopin can be taken on a more preventative basis because it's a long-lasting benzodiazepine, and you can take it twice a day. The other problem with Klonopin is if you take it every day to prevent your panic attacks, you're going to build tolerance, which means you're going to have to keep increasing the dosage, and eventually it's not going to work. And then when you stop it, your anxiety is going to go through the roof. So it's going to be almost impossible to get off of it if you keep taking high dosages on a daily basis to prevent a panic attack, which is why you want to go to the antidepressants. Because there's some evidence that it can be tricky getting off of the antidepressant, especially Paxil. Paxil, there's some people that have problems getting off of it, but the withdrawal effects of antidepressants are much easier to deal with than the withdrawal effects of the benzodiazepines. Much, much easier. So your psychiatrist will not give you regular benzodiazepines daily unless the other therapies are not working. Mainly because they're going to have to keep increasing your dosage over time. From a cognitive perspective, you can deal with panic attacks by helping someone recognize that these are false alarms. Your brain is having a false alarm. There's nothing wrong with you. And if you recognize that there's nothing wrong with you, you're more likely not to have a full-blown panic reaction. So your heart rate might increase, your heart might flutter a little bit, you might feel some tension in your arms, your legs. These are normal fluctuations. You cannot misinterpret them as panic, as like the panic attack is coming, because then you're going to have a full-blown attack and you're going to have to deal with it. And chances are you're going to have a negative outcome. You're going to run in the other direction. You're going to leave work, you're going to leave school, and you're not going to want to go back. But if you interpret these benign physical fluctuations in your body as benign, which they are, there's nothing inherently dangerous about panic attacks, you'll desensitize yourself to them. Everybody's heart does not beat steady like a drum. There's going to be variability. If your heart's beating steady like a drum and never changes, that's not good. That means that you could have some underlying heart disease. Hearts are meant to speed up sometimes, slow down sometimes. You might have some extra beats. They're called premature atrial contractions or PACs. They're very benign. It might feel like your heart's skipping a beat, benign. You may even have a run of those PACs. That's pretty benign too. If you have like, two at a time, it might feel like your heart is skipping, but it's not dangerous. It just feels weird. But if you learn to ignore those normal variations in your body, you won't interpret them as dangerous, and therefore you're not going to go into the full-blown panic. I think another thing you can try, especially if it's heart related, is to take beta blocker, which is a pill that stops the effect of adrenaline on your heart. It blocks the effect of adrenaline on your heart, which then lowers your heart rate and lowers your blood pressure. But also, importantly, it lowers the ability for you to feel your heart beating differently. So you don't really necessarily feel your heart beating when you're on the beta blocker, and that can get rid of that uncomfortable variation that is benign, right? I mean, we're talking about premature atrial contraction. We're not talking about premature ventricular contraction or PVC, because if you have a run of PVCs, it could indicate an arrhythmia. That's something that needs to be examined. But if you've had your EKG and it's come back fine, you had your stress test and it comes back fine, and you had your echo, if they want you to have an echo and it comes back fine, then, especially if you're young, there's probably no chance of it being physical. It's most likely panic attack. And once you realize that, like, I'm perfectly healthy, this is all my body playing tricks on me, if you change that cognition, you're less likely to exacerbate the panic, and the panic will level off. It won't get like out of control to the point where you need to like retreat and run away. And so that's what cognitive treatment is about, changing these disastrous cognitions, like stop disasterizing. Panic-prone people often are very sensitive to normal bodily sensations, and it could be due to trauma. It could be due to the fact that you had some problems health-wise early in life, or you've seen your parents or loved ones deal with health problems. You tend to be high on something called anxiety sensitivity. So you're hypervigilant to your body. That means you're looking for sensations to label them as abnormal, to interpret them as harmful, and that leads to the panic. And so you have to kind of retrain yourself to not focus on all these normal fluctuations that are benign. There may also be something called a biological challenge, where you try to induce panic sensations in the client. So you may have your client engage in vigorous physical exercise, like run up and down a flight of steps, get your heart pumping, or jump up and down so your heart's pumping, and then just kind of like feel it and feel your heart pumping. Maybe your heart's beating out of your chest. That's fine. Maybe your heart's beating fast. That's fine. That's normal. Feel it, and feel that nothing is going to happen to you. You feel that thumping in your chest? That's your heart. It's okay. Your heart's not going to explode. Your heart's not going to fail. It's really not. Unless you have underlying structural heart disease, which most people don't have, especially early in life, you're not going to have an issue with your heart beating fast. Your heart rate could beat 200 beats a minute for a long time, and there would be no long-term damage. Now, obviously, if your heart's beating 200 beats a minute for a long time, a matter of like an hour or 2 hours or more, chances are you have some kind of physical arrhythmia. You could have Wolff-Parkinson-White syndrome, which causes kind of a feedback in your heart that causes the constant acceleration of 200 beats, 300 beats a minute, to the point where you might pass out. Now, if you have something like that, that should be diagnosed by your, cardiologist. Go see a cardiologist, get diagnosed. But you can usually see, like something like that happen. If you go to the hospital, they can see that in EKG, and they'd be able to determine if that was the case. Very rarely is it going to be Wolff-Parkinson-White syndrome. I mean, that's not saying it can't be, but it very rarely. Most of the time, it's going to be panic, other than anything else. It's going to be panic. It's not going to be arrhythmia. It's not going to be heart attack. It's not going to be asthma, severe asthma. It's not, it's not going to be any of that stuff. It's going to be panic, false alarm. So this is a way of like sort of increasing the physiological reaction and then teaching yourself to accept it as being normal. So the next time your heart starts beating fast, you realize, well, my heart was beating fast before, nothing happened, I was fine. So if my heart speeds up, I'm going to be fine. Eventually it'll slow down, and eventually everything's going to be okay. So then you stop exacerbating the panic, so you don't elevate it to a high level.